Hello, everyone. Welcome to our webinar on CRADLE. I am just wanting to make sure that people can hear me. Okay, thank you. I just got a comment there from, thank you, Carly. I am just looking, we're just still waiting for our first speaker to join our call, but welcome everybody to this webinar. This is our second webinar in which I'm just actually trying to see, Megan, I cannot turn on my video. If you can change that, that would be great. And while we wait for that, I just want to welcome you to our second webinar for the CRADLE project, which is being developed by the Schlegel Center of Advancing Seniors Care at Conestoga College. And this project is in partnership with Future Skills Canada, for which we received a grant. So our topic for today will discuss the value of using a team-based approach, and that is in order to support the care for those living with dementia. And we're specifically going to look at strategies that teams can use to support evidence-informed and person-centered dementia care. Before we start, I would like to mention a few housekeeping issues. So if you do have a question, please use the Q&A button at the bottom of your screen, and I will pick that up. You can also look in the chat box, and if you have a question, you can pose it there. We will share any links for the slides and any documents that we're referring to in the chat box while the presentation takes place. And then I also want to let you know that this webinar is being recorded and will be made available on our center's website for those who are unable to make it today. So in starting up the webinar, I think Dr. George Heckman was our first presenter, but I see he has not joined our call yet. So I'll just quickly, doesn't work, sorry, connect with him. My apologies for that. Okay, so he should be joining us shortly. So while we do that, maybe I'll introduce Dr. Heckman. He is a physician graduating from the University of Toronto in Ontario, and he completed his residency in geriatric medicine at McMaster University and completed a Master's of Science in Health Research Methodology at Mac. He is a Schlegel Research Chair for Geriatric Medicine at Schlegel Villages and the Research Institute for Aging, and also is a professor, an associate professor at the University of Waterloo. Just recently, he became the medical director for Schlegel Villages at University Gates, and his research is really focusing on long-term care and comorbidities and chronic disease management, focusing on teams in supporting care. So today I am just checking in if, yes, he has joined us. That is great. So today he will talk to us about how teams can function and collaborate in long-term care and retirement environments to really support the best possible care for our seniors. And so, George, I am passing it on to you. You will have to unmute yourself.
I'm unmuted and immutable. There's no
video. There you
video.
go.
Is that okay? There's no video, but that's okay.
No, that's great. Go ahead.
All right. So it's a great honor for me to speak to you all. I'm in the middle of working with a team right now, and got a complicated clinic starting in a few minutes. And so I think I didn't prepare slides for this because I thought that's really not the story here. I think one of the key stories to tell as a newly minted medical director now in a retirement home, as someone who's been doing research in chronic disease management in nursing homes, in primary care, in specialized heart failure clinics, is that leadership matters. And many years ago, I took a leadership course when I was a resident in geriatric medicine, and I went. It was interesting. I didn't know what to make of it, but somebody said, "Hey, you want to go to Ottawa? We'll pay for it." And when you're a resident, you say, "Sure," and anything for free food. So, but it was very useful. It was very useful because we had talks from a variety of people who had made a difference. Interestingly, one of them was Warren Kinsella, and he was a lobbyist who worked with Jean Chrétien as part of his government and got him elected. And one of the things about leadership is really one of the messages is if you're not happy with the way things are, you need to step up or you need to be quiet. And it's something that I tell all my students now, if you see something wrong, if you see something that needs to be fixed, if you don't do it, no one else is. So that's one of the first things. And the second thing is you might make mistakes. And in fact, you probably will make mistakes. And I know I've made mistakes. But again, you don't learn if you don't make mistakes. You don't want to make too many, I suppose. But if you don't make mistakes, if you don't get things wrong, then you'll never figure out how to get them right. And that's really what's guided the work that I've done. I started my path as a geriatric medicine resident in nursing homes in Niagara, and doing the usual geriatric consults. And what was interesting is that one set of consults for a week, we referred patients with memory loss and functional decline and BPSD, behavioral and psychological symptoms of dementia, the term that really I don't like anymore. And all of these folks had heart disease, all of them, as the major cause for their syndromes, for their cognitive impairment, for their functional decline, for their depression. They all had undertreated heart disease. And when we treated the heart disease, they got better. And to me, there was the gap. And the question was, what is going on with these folks such that they're presenting with geriatric syndromes, but they have something that's fairly simple to treat, fairly straightforward. And what's going on here? And so I took that plunge. That was my reason for starting all of this work. And it's been going on now for 21 years. How do we figure out how to better manage chronic diseases in general, heart disease in particular, in nursing homes? And I quickly realized that this will never get better unless we truly work as a team. And the question is, what's a team? When I trained as a medicine resident, until I did my geriatric rotation and got a talking to by the nurse, I thought, naively, I guess doctors are at the top of some sort of hierarchy. I mean, that's how we're trained. In fact, I had a student go to medical school a few years ago and came back and said, what the hell is going on? We were told that we are at the top of the heap. And she quickly realized sooner than I did as a student that that's not the case. But I was not exposed to this until I did a geriatric rotation at the Toronto General. And I still remember her name. Nora was the charge nurse. And I learned probably more from Nora than I did from anyone else in my career. And so when I started doing my work in nursing homes, and we said, you know what, let's talk to everyone. And let's talk to them separately as equals. Separately because maybe they don't get along. Maybe there's a power differential here. So we spoke to the PSWs and the nurses and the pharmacists and the doctors all separately. And clearly there was this power differential, and this power differential was sort of a cultural one. It's not that the doctor has PSW expertise or vice versa. It's some sort of imposed culture, which sort of seems to suggest that we're all different. Yeah, we're different. We have different skills, but from a patient's perspective, we're equal, and more equal than we realize. And it was that revelation that until we get people to truly understand what this means, to be humble, to listen to the other person, to consider them as an equal expert. There's a different set of knowledge and expertise, but until you start considering people at that equal level, we will never, ever achieve improvement in the care of the residents. And so that's something that I do with my research. It's something that I do clinically all the time. I do shared care. I do shared care research. And I go see the residents with the rest of the team. And I said, come on, let's go see Mrs. Smith, or let's go see Mr. Franklin, or let's just go see them together and let's figure it out together. Without their input, I can't figure anything out. And the interesting thing, I think, is best encapsulated in two stories that I'll tell you about what it means to work with the team. So when you work with the team, you learn from one another. And a couple of months ago, in one of the nursing homes where I do consults, we were asked to see the behavioral support team, the PERT team, the personal expressions resource team, was asked to see a resident who, after lunch, would walk back towards her room. But as soon as she saw an open door, she would go into that door. It was not her room, but she'd go into somebody else's room and sit on the bed. If there was a person in that bed, she would still sit on the bed. So that person was not happy about that. And sometimes she'd even poop on the bed or on the person. So clearly not the best kind of situation in terms of personal expressions. And so the personal expressions resource team, or the BSOs from the nursing home, were asked to assess, and I'd worked with them for years now. And some of these folks are able to see heart failure from the corner of the room. They can look across the room and they can see someone who can't breathe and may have heart failure. And this personal support worker went for a walk with the resident and noticed very quickly the resident was extremely short of breath. And basically the resident, by the time she reached the room, she needed to sit down because she was very short of breath. And so they asked me to see this person. Long story short, she had severe aortic stenosis. And so rather than using medications or restraints, we just moved her to a closer room and the problem was solved. Right? So this is an example of an intervention that could never, ever have happened if we had never worked as a team. Period. And I think the second story, again, same idea, another nursing home where we worked as a team. We shared the assessment times, we learned from one another, and they were telling me about a resident who had moved into their nursing home as a palliative end stage, we don't know what. So he was just end stage functional decline, end stage delirium. This poor fellow required a Hoyer lift, was completely incomprehensible, and was basically sent from the hospital to the nursing home to die. And this team with whom I'd worked assessed this gentleman and said, you know what, it's heart failure. They went to talk to the MRP, to the physician, and the physician said, yep, sounds like it. And they treated this man. And it was like Lazarus resurrected. Basically, it was heart failure. And he went from delirious to only mild cognitive impairment to walking with a walker, and he lived another 9 months. Very happy man. And again, this is sort of the legacy of the training that we did as a team. It would probably not have happened any other way. And so, again, no slides. Happy to entertain some questions, but this is my teamwork story. Thank you.
Oh, that's great, George. Thank you. I did see one question pop up, if I may. The question is that, as you know, there's a lot of new hiring in long-term care because of COVID. What do you think is really important for a long-term care organization to really make sure those people are on board?
Are there any ministry people here? Because the first answer was pay them well, pay them a lot more. I mean, yeah, maybe I think they're underpaid. This is hard work, and I think that needs to be fixed. The second thing is they're adults. They're doing this job because they like it, and they're willing to learn. And I treat them as I would any neighbor, any person that I meet, as equals. There's no hierarchy. I insist that there's no hierarchy. And, I listen to them. And that's the key bit. Listen to them. They're interested in learning about their residents. They want to know what makes the residents tick. They're invested in this resident being well. And there's nothing more rewarding for someone to, get some knowledge about how to observe a resident and identify when they're sick and be that person that brings them to the attention of maybe the nurse or the doctor, and that resident will do better. So, respect is remunerative, obviously, but also treat them as people who are doing an extremely complicated, important, difficult job. And they have a lot to say on behalf of the resident.
Yeah, thank you for that. And you actually, I couldn't agree more. And you, by answering, you also addressed the second question that popped up, and it was related to how do you communicate? What are some of the communication that needs to be in place between PSWs, physicians, nurses, family? But I think you alluded to that by just making sure that you can listen to each other and value everybody's input. You go a very long way.
Mm-hmm. Absolutely, absolutely. One of the strange things is when you do chronic disease management, say in a heart failure clinic or in a primary care clinic, we always insist on bringing the family caregiver in to provide collateral, to make sure that whatever information is shared with the resident who might have cognitive issues or be in pain, make sure that it's understood. Well, that personal support worker, that RPN, in many ways serve as that care provider for that resident. In many cases, they will have family care providers, but most of that care, most of that bedside care will be the RPN and the PSW. And it's always been strange for me that we don't consider them as such, because they are. And if we don't consider them as such, we will miss really important things. So.
Yeah. Thank you for that. And thank you for your talk. I know you're on a very tight schedule because you're in clinic and your next patient is waiting for you. So if there is no further questions, George, then thank you so much for your contribution today. And if anything else will come up, we're happy to follow up with you.
Thank you, and happy to take emails. You can give them my email. Happy to take answers or questions.
Okay, great. Thank you so much.
Bye-bye.
Bye now. So thank you, everybody, for your understanding. We had to kind of change the schedule a little bit because of George's clinical schedule. So I'll just maybe do a quick overview of our webinars and then our next speakers to set the stage a little bit. But we didn't want to miss the opportunity to be able to find Dr. Heckman's input on teams and long-term care. So I just want to acknowledge that and thank our funder, Future Skills Canada. We're funded by the Government of Canada to do this project, and many of you are part of our advisory committee. Without you and without the funder, our project would not be possible. So thank you for that. And then for our team, our Schlegel Centre for Advancing Seniors Care, we are funded by the Canadian Institute of Health Research and some other grants. And our goal is to develop innovative education to improve workforce to support care for seniors across Canada. So we started in 2012, and in the meantime, we've been just able to work our way. So then the reason why we focused on our next slide, the reason why we focused on this specific project is that we all know, I think I speak to the converted, we all know that unregulated care workers are the largest paid workforce in our Canadian healthcare system, especially in seniors care. And so they're often unrecognized and unsupported. But they also have the highest risk working conditions. They also present with high job turnover, and they have poor retention overall. So clearly this is a layer of our healthcare system that needs attention. And given COVID and what has happened in the past, we've seen that unfolds very rapidly. Although I would like to say I would love to see a more rapid response. So, and then talking specifically about people living with dementia and caring for those people, I think Dr. Heckman alluded to the fact that that is really, really complex to provide care to people living with dementia. And unregulated care workers might not always have received the skill set in order to do so. So that's how CRADLE was born. On our next slide. So CRADLE really stands for the Canadian Remote Access for Dementia Learning Experiences. It's a 2-year project in which we are aiming to train 50,000 unregulated care workers. We're nothing but ambitious. So with our partners on board, we are developing this program to make it available at no cost for unregulated care workers that are employed in home care, long-term care, and retirement living. And we're aiming to open up the first course in January 2021. So there is a small evaluation study tied into this that we're looking at online surveys, pre and post, to really evaluate what unregulated care providers think of this specific course and then of their employers. And then today, really, our 3 panelists are looking specifically at issues related to caring for people living with dementia from a team perspective. So how can teams really support the role of these unregulated care workers? And where do they really need to have some support and backup to make sure they can do the best they can? So I know Dr. Heckman talked a little bit about that from a long-term care perspective. Our next speaker, which is Dr. Catherine McGilton, is going to look at this perspective from a nursing angle and to really look at optimizing strengths to support unregulated care workers. So it's my great pleasure to introduce Dr. Catherine McGilton. Kathy is a senior scientist at Toronto Rehab Institute at University Health Network, and she's also a professor at the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. Kathy has been a leading researcher in Canada and internationally at looking at the workforce in long-term care, and she's received many grants from CIHR, the Alzheimer's Society of Canada, and the ministry, amongst other funders. Kathy was recently inducted in the Canadian Academy of Health Sciences Research for her work, and really looking at her interdisciplinary approach to practice and education and support for long-term care. Kathy is also the co-lead of the Quality of Life team on the Canadian Consortium on Neurodegeneration and Aging, and her work has very much focused on relationship building between nurses and other staff with older adults, and then on supervisors and their work and role in long-term care. So with that, I'm passing it on to Kathy for her presentation. Thank you.
Great. Thanks, Veronique. First of all, it's very exciting to be part of this team. And I'm thrilled that you're going to be working with personal support workers. I think there's a huge need to continue to advance their practice skills, but also for everyone to recognize their importance in nursing homes and the value of having excellent personal support workers in your facilities. Next slide. So I'm like, sorry, George, I come bearing slides. So I'm going to be talking about optimizing strengths and care teams, integrating our unregulated care workers. Okay, next slide. So I have some definitions. We'll go very quickly because you all know this. There are paid workers who are neither registered nor licensed by a regulatory body and have no legally defined scope of practices. And I think Veronique's doing some work in this area, and probably some of you on this call as well to change that. Some of their duties really varies by location, but traditional role sort of includes support for activities of daily living, also for instrumental ADLs, especially if people are these care workers are actually in people's homes. There's also now a focus more on physical kind of rehab and also light housekeeping. Next slide. Okay. Okay. Great. There's no educational standard for these workers in Canada. So different provinces have really taken this on to try to get a sense of what kind of curriculum should be available. And in terms of registries, they're relatively new. And if they are in place, they're not yet comprehensive to all unregulated care workers in all places of work. I mean, I think there's also an issue with some of these registries because they have to pay, but I'm not sure what the benefits are for them. So I think there is some issues related to that. In terms of demographics, it's difficult to track. The exact size of the workforce is actually unknown in Canada. It's estimated there are approximately about 100,000, and in particular in Ontario, about 44,000. Individual studies have found this workforce numbers are primarily female, on average around 46 years of age, and half hold a certificate or a diploma in a different area. Next slide. So the role is definitely evolving. So we're seeing, in fact, most of these unregulated care workers were providing direct care, and now expect to perform tasks that the RN and RPN had done prior. For instance, selecting appropriate assistive devices, assisting with wound, hearing aid, and sometimes complex bowel care, bladder catheterizations, tube feedings, observing vital signs, nutritional intake, assisting with medications, collecting specimens, and performing a range of motion exercise and rehab tasks. So some of these contributing factors are really the complexity of the client that are showing up in our nursing homes, and George alluded a little bit to that. We have increasing number of aging populations. We also have nursing shortages and fiscal constraints. So the role is definitely evolving. Next slide. So in terms of evolution, there's a slide here that sort of speaks to some of that, and I do have references for you if you'd like to look at it later. But again, there's also a focus on more documentation and additional tasks that even promote more activities, even hearing aid care, for instance, which is incredibly overlooked in visual impairment. Okay, next slide. So I think we are really realizing that they're playing such a vital role in our healthcare system. And I guess the question that I was left wondering is how come they're not recognized as an integral part of an interprofessional team? And how can we work to better integrate them with a focus on care for the older adults? And so this is what Arslan has actually talked about. Next slide. There are many challenges that unregulated care workers face in these teams. So the reported challenges, there has been some research conducted in this area, are the vertical power hierarchies within the interprofessional team. So I just loved how George talked about this, how we're all equals. We all want to work together, respect one another. Unfortunately, not all personal support workers feel this way. And in fact, I remember one of my first articles I wrote, we talked about the paramilitary kind of levels of hierarchy, even just within the nursing division, where we have your director of care, then you have a charge nurse, maybe an RN, RPN, PSW. Lack of intentional collaboration with the PSWs. Sometimes they're not involved in team meetings. This was very typical 10, 15 years ago when I was starting to do research in this area. Lack of role clarity, so there's a lot of confusion about the role. Limited role in overall plan of care, access to updated care plans. I remember supervising Sienna Casper, and she talked a lot about this in BC, where some of the personal support workers couldn't even access the care plans. Inadequate training, supervision, and staff. Next slide. Obviously, we need to do a better job at including the vital members of our team, the personal support workers. So we actually have to engage them more in our teamwork. And there is evidence, the more we do this, it improves workload, outcomes, and overall quality of care received by the residents. And also accessibility of the unregulated care worker. They spend the greatest amount of time with residents and their families, so they're very well positioned to be familiar with unique needs and any subtle changes. And I remember working with Barbara Bowers, who is an international expert in this area, and she basically wrote a study, and it was quite beautiful, how most of the times, because the RNs and RPNs are often pulled into different tasks, because the personal support worker is often closest to the actual client, that they would notice subtle changes. And one of the most important ones was when they said good morning to the client. And the way that the client responded often cued them to the fact that there actually could be something physically, emotionally, cognitively wrong with the client. So it's very subtle nuances that once you know the person quite well, it's very important listen to what the personal support worker has to say. So there's really an important role for our, they should be part of our team. We've got to start listening. And in terms of assessment, health promotion, and care planning, they're definitely required to be part of the team. Okay, next slide. Well, I'm going to talk about then the challenges, but then I want to talk about possible solutions, because I think that's what we want to focus on. And I absolutely loved George's comment around leadership. And if you're not happy, you need to step up to the plate and do something. And I think that is so beautiful. And I think about that as I look at these solutions. There are power hierarchies, and there is absolutely sometimes an issue with respect of the job that they're doing. And so I think there is a reality. There's not a lot, I mean, there's wonderful that George is George, but I'm not sure all our physicians and even our RNs think the same. So potential solutions: administration can host increased informal and formal communication forums to discuss the value of each team member's role. Sometimes we just have to talk about this. In-house education sessions are important. Clarifying the roles, the importance, and even team building activities might be essential. There needs to be an increased focus on preventing burnout. And again, as Ronnie reminded us, COVID-19, this has made this even more essential. What are we doing to support their emotional, social, the stress and burden that is happening? We know that administrators, supervisors can acknowledge the complexity of caring for residents with dementia, working with personal support workers to help them with some strategies, and supporting them whenever we can without blaming them. I think we have to listen and hear their stories. And I've done some work in nursing homes, and often that's what we hear from PSWs. They didn't even listen to my side of the story. So I think we have to be very careful. There usually are two sides, and sometimes it's actually a reframing and a reteaching of perhaps another approach to working with this person with dementia who is upset at the moment. Next slide. Another major challenge is the lack of intentional collaborations. And I remember working in one nursing home, and the director kept saying it's nursing staff and others. Like she wouldn't even make them intentionally. She said, you know, we can't call them nursing staff. We can't. So I always felt they were incredibly excluded. And so our language is very important. And I think we have to intentionally think about the team. And I liked how George talked about that. The team is all of us. And so we have to collaborate and do this together. That means being involved in family conferences, decision-making opportunities, because again, most of our personal support workers have a very good understanding of what the resident needs. Inviting our personal support workers to be involved in the team huddles, care rounds, which can contribute to safer, more comprehensive person-centered care. And also that there's a handover. I think this is also really important that, you know, once we have those during the shift and we're moving over, that also, again, our personal support workers are part of that, so that we can hear what's happening and we're part of maybe solutions and sharing of strategies that worked the last shift, so we can pass that along to our colleagues. Next slide. I think this is also a big problem, and I think this is where Veronique's grant, we can make a difference. Inadequate training and staffing. Well, I'm not sure about the staffing, but for sure inadequate training. So providing more opportunities for education and ongoing support is crucial. The client population is changing. We need more information, we need best practices, and we need to have them implemented. I think it's one thing to have the education, but then what's the ongoing support that's required? I think there has to be a facilitator somewhere, because it's one thing for any of us to go to an education session and learn about important ways to deal with persons that become upset. But the next thing is, once you have that client in front of you, how do you apply what you just learned in the classroom into that practice and make it very centered, person-centered to that individual? That actually requires a sophistication and sometimes some coaching. And often in some of the models I've seen, that comes from either a nurse practitioner or an RN. We need to have more time to actually work within the teams, to talk about even how to delegate more appropriately, how to assess when there are changes happening, and monitoring to make sure that we're within the scope of each other's practices. And the next slide. And probably where I focus most of my energy on is this notion of the supervisor. So who are their direct reports? So when I started my dissertation in 1995, what I noticed very quickly was, depending on the RN who was supervising at this point, the personal support workers, they made a huge difference in the quality of work life for this personal support worker, but also the direction and influence of the work of the personal support worker. So I couldn't help but wonder, shouldn't we have kind of that same mirroring of a relationship between what we want a personal support worker to be like with the resident, which is empathic, reliable, dependable, listen to the resident. We want the same qualities when we looked at the supervisor supporting the personal support worker. So I've developed a scale looking at this, where actually PSWs rank their RNs or their RPNs, who the direct report are. And we've done this in several studies, and it continues to be the #1 reason why, in terms of intent to stay or even turnover, if there isn't a good supervisory support situation. So we have to really appreciate the importance of having effective supervisors in our nursing homes. So we have to provide opportunities to get these RNs and RPNs at a level where they can supervise effectively, because I know in my training as a nurse, I never got principles 101 of how to lead, supervise effectively. So we need to provide more skill to the supervisor on how to actually develop responsive leadership strategies, more encouraging two-way information exchange, timely follow-up, supportive behaviors. We need to have more of this happening versus less, and a real notion of supporting one another to transfer new skills, especially the RNs. And that would mean the director of care in the home. How are they helping to support the RN in these kind of new leadership supervisory ways? And then finally, this notion that we need new models of care. Even as I speak, it sounds like there's still hierarchies in what's happening in nursing homes. And I think where I've seen differences are things like neighborhood models. And that's one of the things Veronique's been trying to do, are better ways to look at how to engage personal support workers, where we sort of look at organizing the delivery and services differently. And she can probably speak more to this than I can. So anyway, those are some of the solutions. And I think the last slide is just some of the references that I have that you're welcome to look at. And I guess at this time, if you have any questions, please let me know.
Thank you, Kathy. That was wonderful. I think, in a very succinct overview of some recommendations and some policies. I invite attendees to put questions in the chat box if you have any, or send them to me. And while that is happening, Kathy, I know that your area of research has focused a lot on the supervisory role. That is so important for PSWs to stay in these often interesting working conditions. Is there some things that you've heard from supervisors that seem to be working really well?
That's a good question. I think it's really getting to know your individual personal support workers, almost like what makes them tick and what are their strengths, and making sure that they're thanked for their shifts. So it's one-on-one. It's calling them out when they do something wonderful, and maybe supporting if they need, but privately, if they need a little bit of mentoring, so that there's a real acknowledgement of how important you are as an individual, what your strengths are, what you need to build on, and how we're going to work together to get us all at a better place. So I just think being reliable and dependable as a supervisor makes a huge difference in terms of the personal support workers wanting to come to work every day.
Yeah. And so I do see a question coming in. So building on that, what have you seen being the greatest barrier for supervisors to act in that way?
I think when they don't get it themselves. So I really believe this has to be a trickle-down effect. So we just published a paper, and this was fascinating, where we looked at nursing homes across Ontario. I think we have about 360 nursing homes reported data on their supervisory levels within nursing homes. So some PSWs rated them very high and some very low. So then we went into those facilities, those that were ranked high and those that were ranked low. The differences were night and day within the culture of the home. And what we saw was this unbelievable trickle-down effect, where we had administrators helping personal support workers, sometimes doing assessments of the clients coming in. We had RNs helping the PSWs whenever was required. It was a pitching in to meet the needs of the person at the moment. And it wasn't so much, it's not my job, it's all of our jobs. So we saw very big differences within the organization. So the person that's in charge of this is the director and the administrator of setting that culture of getting to know one another, helping each other out, and being very specific at meeting the residents' needs, no matter who you are. So there was a real blurring, and I wouldn't say they went out of their scope, but a real making sure that we all took care of the person. You never heard, "This isn't my resident." It wasn't allowed. So there was a tone set by the administrator to say, "We are all in this together." And therefore you saw the supervisors were acting that way, and the resident, and then the PSW is working that way towards the resident. It was actually quite beautiful.
Yeah, that's great. And that aligns so well with what George was saying too, about really you need to get to know each other as in a team so you can actually build on each other's strengths. That's I think the main message that comes through. Thank you. And then I see one more question, Kathy, if that's okay. How hard is it to change the culture in a home that really does not have a team culture?
Yeah, I think that's a fabulous question. And to be honest, I've never really delved into that. I was, the last one I talked about was it just going in and observing the differences and trying to understand them and realizing it was the flexibility within the roles. I don't actually know how to change that. Veronica, you might even have more work done in this area, but I think it's a constant kind of checking of what the vision is and how you're going to get there. And, you know, constant check-ins. Are you anywhere closer to that? So what's your vision and what's the process you're going to put in place to get there? And it could be that people are starting to take, again, looking at specifically what everyone's roles in, how are we going to be a little bit more supportive in this role and in this organization to help one another, and really be focused on meeting needs of the residents. At the end of the day, that's why we're all here. So it's that kind of idea that person-centered care can't happen unless we have sort of person-centered staff care or relationship center. I like to go more to the relationship-centered, and that we need to focus on building relationships among staff, but also then staff and residents. And so I've done a few things where we've actually taken RNs and RPNs and given them some courses on responsive leadership, but also to include the director and the administrator, because it has to come from all different levels. And that's worked to some extent.
Yeah, great. Great. Yeah, thank you for that.
Okay.
Thank you, Kathy. Given the time, I know there's another question popping up, but maybe I'll save that till the end. Given the time that we have left, I would like to introduce our third speaker now to build on, I think, what George and Kathy have done so eloquently. Our third speaker, which I'm very happy to introduce to you, is Dr. Rosalind Compton. Rosalind will talk a little bit more, I think, from the community perspective on what's important in under really understanding what is happening in serving our older adults best. And so Dr. Compton received her PhD in nursing from the University of Alberta and is right now an assistant professor at the College of Nursing at the University of Saskatchewan. And Rosalind's interest has really been focusing on research related to aging in place, being independent, and then really sharing experiences of learning about gerontology and about providing care to those that are older. And so Rosalind also does work on social, cultural, and institutional narratives influencing those stories. So, and involving families in that. So we're very delighted to have Rosalind joining our panel today. And so Rosalind, I'll hand it over to you.
Thanks very much, Veronique. It's an honor to be here today and have this opportunity to further the conversation around caring with older adults in no matter what setting they're living with. And I really like the way Kathy was ending her conversation, which ties in great with my presentation today. So if we'd advance the slides, that would be great. The next one. So the talk that I'm going to have today is on caring in relationship through stories, which really takes from where Kathy was talking, from moving person-centered care into relational care. And what I want to do today is to go towards seeing me. Who is me when we're providing care? Next slide. So these are just some quick learning objectives to think about as I'm talking through this, What is relationship-centered care? Is there an example in my work where knowing a person's story has informed my care? And looking at 2 ways you can encourage relationship care. And I think this comes to that question that was just raised about how do we change culture in the workplace, particularly to relationship-centered care and team-based care. So next slide, please. So to start today, I'd like to read this. Who do you see when you look at me? An old woman, a past life, memories lost, a task, my diagnosis. So we're going to think about this person in the slide here. Her name is Maria, and we'll think about her during the presentation. Next slide, please. So when we think about shifting to a relationship-centered care, so person-centered care has been the primary focus of most healthcare systems within Canada. However, when shifting the focus from caring for a person to caring with a person, building meaningful relationships with the person, their family caregivers, or their person of choice becomes critical. When we think about relationship-centered care, it recognizes quality care happens when strong, reciprocal, and interdependent relationships are built with everyone who is involved in caring. This is inclusive of the person living with dementia, their family members or their persons of choice, and all staff. And as we've heard today, all staff includes the unregulated care worker. They are a member of the team, and they have critical knowledge and understanding of the person the team is caring with. Here I encourage you to focus on the idea that as members of the care team, we do nothing to me without me. We need to see beyond just the resident and embrace care that is inclusive of all the voices. Central to relationship-centered care is the concept of interdependence. Many Western cultures promote independence as the key of successful aging. However, I encourage you to move beyond this dominant story and imagine us all living interdependently. Here we may ask and receive help without being considered dependent. By living in a relationship with others, we can more easily accept that we, at some point in our lives, will ask and receive help. This asking and receiving does not make us dependent. The exchange of help confirms our presence and also our ability to contribute to the health and well-being of another person. The next slide, please. So when I started to wonder more deeply about my nursing and how I practice care and relation, I began to ask questions. After many years of examining my questions, I found personal reflection on the following 2 questions to be fundamental in advocating for a cultural shift in caring with rather than doing to or for a person. The first question is, what is the dominant story told and retold in many Western cultures about persons living with dementia? The second one is, when I listen with the stories persons living with dementia share with me, who do I see in front of me? A person who has lost their ability to tell stories that make sense, that connect their past experiences with their present lives, or someone who can tell new stories as they interact with me and other care providers. As you think about my questions, maybe you have other questions to reflect on to help you move towards a practice that begins with building relationships. Next slide, please. So stories informing caring. In my work, I often see staff and sometimes family caregivers forgetting older adults living with dementia have experiences and knowledge to share. Residents tell me they are rarely asked for their help and they feel they have nothing to contribute to the lives of others. By taking the time to stop to engage in meaningful conversations that extend beyond the everyday task, we take the opportunity to learn from each other. It's in this process of communicating verbally or non-verbally that we build a reciprocal and interdependent relationship. Through our relationships and attending with stories, we discover new meanings and opportunities that can inform care. We also engage in creativity and innovation. We promote abilities and a different way of being in relationship, which optimizes new possibilities of change. Next slide, please. So seeing me. When we think with stories and how they inform care, let me share a story that I am sure you can all relate to. It's 9:30 a.m. and Mrs. Smith is your third shower for the morning. As you walk to Mrs. Smith's room, you remember staff telling you, Mrs. Smith is challenging when it comes to showering. She resists showering. However, she is not able to tell us why. Let's take a moment to think about the possibilities why Mrs. Smith may resist being showered. Maybe it's too early. Maybe she's afraid of water. Maybe she has pain. Or maybe there's something else more complex going on with Mrs. Smith. There's only 4 possibilities here, but I know you can identify many more as you remember different residents who did not or do not like to be showered. What were their stories about the showering experience? Did you carry their stories, told through their words or their bodies, into their care plan? Has the sharing of resident stories with the care team changed the language used to label residents as resistors, challenging, difficult, or non-compliant? When we approach care relationally, we include all care team members in searching out the why, in understanding the story behind Mrs. Smith being labeled challenging when it comes to showering. Later in the day, Mrs. Smith's family comes to visit. You take a moment to stop and talk with them. When talking with Mrs. Smith's family, they share with you Mrs. Smith's story of always preferring a cold shower. In caring with Mrs. Smith's story, you return to her care plan and you write, Mrs. Smith prefers a cold shower. If the water is too warm or too hot, Mrs. Smith will push away from the water or resist showering. Next slide, please. So seeing me, a man moves into long-term care and every evening he goes down the hallway knocking people into the wall. It seems very deliberate and purposeful. The staff are baffled by these events. All our interactions are positive and pleasant with this man. One staff member decides to take on the challenge. She watches him and talks to the family to gain insight into his past. Guess what they discover? Click, please. He's a hockey player. So every evening the sun shines on the floor and it looks like a hockey rink, and the man skates down the hall checking the people into the boards. This man does not need medication or segregation to assure the safety of residents in himself. He needs the blinds lowered before the setting sun turns the hallways into a hockey rink. This man's story demonstrates how sharing knowledge gained through attending with stories within care teams, inclusive of the person and their family and their persons of choice, can inform the development of care plans and interventions that optimize health and well-being. Next slide, please. We're going to return to this story shortly, but here we're talking about having a conversation with the resident and family members. The care provider learned the woman enjoyed looking at the stars. She had been fond of the star constellations and watching the night sky. So keep this story in mind, and we're going to come back to it when we reimagine stories. Next slide, please. So when we reimagine stories of possibility, when I think about this, I ask myself these 2 questions. Do I stop, listen, and consider how the stories persons living with dementia tell through their words or bodies may be integrated into their care plan to inform their care and interactions with the care team? Do I reflect on my personal stories and how these may influence my care and relation, caring beyond the tasks required in my everyday work? Next slide, please. So let's think about possibilities. With these questions in mind, we'll return to the woman and the stars. What are some possibilities for reimagining care inclusive of her interests and experiences? For some care team members, the list that I've provided may include possibilities they perceive to be beyond the abilities of the person living with dementia. However, we must remain respectful, open and playful to the suggestions and ideas of possibility and interventions shared by all team members. As you think with stories, can you imagine sitting next to the woman on the balcony, looking up in silence at the beautiful night sky in awe and amazement? There are many stories being shared in the silence, none of which require words. Next slide, please. So thinking with and about stories, and the 2 questions that I posed right at the beginning, think about the dominant story in your workplace And do you take the time to listen? As we return to our workplaces, I encourage you to take a moment to think with and about stories and return to these two questions and reimagine them in relation to your workplace and the work that you do. I encourage you to return to these questions often. By seeking out answers, you will have opportunity to explore what it means to care in relation with another person and how reciprocal and interdependent relationships and stories inform care. Through sharing experiences, you can encourage others to think about caring in a different way and become an advocate for changing the way we care with and about persons living with dementia, their family caregivers, and persons of choice, and the care team. Next slide, please. So becoming an advocate. You are the person working closely with the persons living with dementia and their family caregivers must become an advocate and promote empowerment, equality, and social change. And both George and Kathy talked about that today. To do this, we must embrace change that begins with us. We can't wait for others to do and make change. We need to make change ourselves. Here are some suggestions for helping you to shift the culture in caring, which might help to answer the question previously asked. To value and know each other, to believe everyone can learn and grow, to value interdependence, attend with stories, stay flexible and responsive to change, and remain open to new possibilities. I encourage you to start small and acknowledge your successes, no matter how small you believe them to be. I also encourage you to acknowledge mistakes and grow from the experiences. Advocacy is not easy work, and it takes a strong commitment to practice relationship-centered care, to see me in every person. Next slide, please. So here we return to Marie. Who do you see when you see me? Possibilities, new learning, experience, stories to share, me. Thank you for seeing me. Next slide, please. These are just a few suggested resources that you might like to look at. And the next slide. I'd like to give great thanks today. Thank you, Marie, for giving me permission to share your photograph. Thank you, Deb, for sharing your work and stories with me to enrich the presentation. And a special thank you to Charlotta for sharing your stories and expertise with me in developing the presentation. And thank you, everyone, for taking the time to see me when you go back to work today and the next days as they come. And thank you for the opportunity to present.
Thank you, Ross. So that was wonderful. I love the slide that says what are some of the opportunities here, be an advocate, and I think I should print that one out and put it out there. I think that's great. Kathy and Rosalind, with your permission, can we post your email address in our chat box to see if people have any more questions?
For sure.
Thank you, Rosalind. And Kathy, is that okay with you as well?
Oh, you bet.
Okay, thank you. I know this is so interesting and I want to ask a lot of questions, but I also realize we're at the end of our time. So thank you so much to all of our presenters today, George, Kathy, and Rosalind, for sharing your wonderful experiences, stories, and research. I truly enjoyed listening to all three of you and just how amazing it is that story streamlines from one presenter to another. Lots of interesting learnings here and some action items for us to move forward. I also want to thank everybody who attended today and for our partners in this grant. We could not do this without you. And I also want to take quickly the opportunity to make sure that everybody knows that this presentation will be available online if you want to use it in your environments, or if you want to use it to teach or to share with some of your colleagues, that would be wonderful. In the next 2 months, we will be starting our third webinar as part of this 12-part series. And in that webinar, we will actually be sharing some of the CRADLE courses and videos. If you are interested in that, I'm happy to have you join us. We will send out information on that as well. And so that really concludes our webinar for today. Thank you so much, all of you, for joining us today, for learning from each other, and for creating a partnership and a network in which we can strengthen care for our seniors in Canada. I hope you have a fantastic day, and we hope to see you at our next webinar. Thank you all.